Okay, let's unpack this mountain of technical notes. Welcome, everyone, to a seriously in-depth deep dive into advanced knee surgery. Specifically, we're locking down on the evolution, the current mechanics, and the clinical efficacy of all inside arthroscopic meniscal repair. My mission today as your guide and, a resident who's eager to avoid complications is to really absorb these critical notes and surgical pearls.
Right.
We are diving into the biomechanics, the material science, and, well, the molecular biology that determines whether a meniscal repair holds for decades or fails within just a few months.
And my mission as the surgeon who has spent years in the operating room and frankly even more years in the follow-up clinic is to make sure we move beyond just the mechanics of deployment. We need to understand the sheer clinical significance of this procedure. This isn't just a technical exercise. I mean, this is critical for a patient's long-term knee survival. We aren't just stitching up a tear. We are trying to preserve the entire viscoelastic and biomechanical integrity of the joint to prevent a catastrophic long-term morbidity, and that is early, devastating osteoarthritis.
And that necessity, the why we have to repair, that's the foundation of this whole discussion, right? It was established decades ago. The famous Fairbanks observation from 1948.
Absolutely. That foundational work really showed the profound long-term morbidity that comes with a simple meniscectomy. If we just go in and excise that tissue, we are, for all intents and purposes, guaranteeing degenerative joint changes down the line. The moment you remove meniscal volume, you drastically alter the fundamental contact mechanics of the tibiofemoral joint. It's an unavoidable functional loss.
And to hammer home the scale of that loss, let's just quickly revisit the numbers on load bearing. They're pretty staggering.
They are. And they should be a constant reminder of why the meniscus is so important. The lateral meniscus, it handles approximately 70% of the tibiofemoral contact pressure. The medial meniscus accounts for about 40%. So a meniscectomy increases both the peak and the mean contact pressure substantially. And that rapid, concentrated shift in loading, that's the kinetic engine that drives early degenerative change. So repair, whenever and wherever it's biologically possible, is really the only choice if we care about the long-term health of that joint.
Okay, so I always picture the meniscus primarily as a simple shock absorber, just a compressible cushion. But your analogy, comparing it to a specialized hydraulic system, that suggests something way more complex. What are the core functions beyond just absorbing impact, and how does its material composition support those roles?
You really have to think of it as a specialized, dynamic, viscoelastic structure. Its composition is fascinating. It's 70% water, which, yes, contributes to its dampening effect. But the crucial 30% organic material is predominantly type I collagen. And this specific collagen arrangement, primarily in these circumferential bundles, gives the meniscus this unique capacity to withstand and manage massive circumferential loading. We call that hoop stress.
So that type I collagen structure provides the tensile strength. It lets it act like a perfectly tensioned rubber band resisting outward displacement when the joint gets loaded.
Precisely. If that ring is intact, when you apply force axially, say when you jump, the meniscus tries to displace radially, but that circumferential collagen resists it. So beyond load transmission and shock absorption, its biomechanical functions are just critical. It contributes significantly to joint stability, particularly resisting that anterior-posterior motion of the tibia relative to the femur. It also provides crucial proprioception. It gives the knee its sense of spatial position. And it acts as a vehicle for articular cartilage nutrition, distributing synovial fluid across the joint surface during motion. So when you compromise the structure, you compromise the whole integrated system.
Speaking of compromising the structure, that brings us right to a topic that has, I think, redefined our urgency for meniscal repair in the last decade, the posterior root tear. We know a simple partial meniscectomy is bad, but why is a root tear considered, functionally catastrophic?
Oh, the root tear, particularly of the medial meniscus, is devastating because it instantaneously abolishes that hoop stress. It is functionally equivalent to removing the entire meniscus. Biomechanical studies have shown this definitively. A tear involving the posterior root behaves functionally similar to a complete medial meniscectomy. And it's all because of meniscal extrusion.
Extrusion being the key word there. It slides out of the joint space.
Exactly. Imagine that tensioned rubber band we talked about. If you cut the anchor point, the root, the meniscus, is no longer anchored to the tibial plateau. It can't resist the radial forces. It extrudes or slides out, and therefore it cannot generate the hoop stress that's necessary for load distribution. It's like cutting the mooring line on a boat. The structure is still there, but it just drifts and becomes functionally useless. And that leads to rapid high-pressure loading right on the articular cartilage. Repairing that root, if you can do it effectively, re-anchors anchoring the line is proven to restore near normal contact pressures. And that's arguably one of the biggest orthopedic wins for joint longevity we've recognized recently.
Okay, so understanding that repair is the absolute goal, how do we frame this all-inside repair technique that we're talking about today, relative to the traditional methods?
Well, first we have to establish the traditional battle-tested benchmark, which is the inside-out vertical mattress repair. That procedure, where the surgeon passes long needles through the tear and then ties the suture over the capsule, is still the gold standard in terms of mechanical fixation.
And why is that? Why is it the gold standard?
Because the vertical mattress configuration provides the best mechanical stability. The suture tension is perpendicular to the dominant collagen fibers. However, the inside-out technique requires accessory incisions in the posterior or posteromedial aspect of the knee, and this significantly increases surgical time, technical difficulty, and, most critically, the inherent risk to those major neurovascular structures that are lurking just outside the capsule. The all-inside devices we're focusing on today emerged precisely to try and achieve that gold standard mechanical result, but with decreased surgical time, a simplified technique, and most importantly, a massive reduction in that neurovascular risk profile.
That smoothly moves us into indications. We want to repair every tear we see, but biology always dictates the final outcome. And while MRI gives us a preoperative prediction, the sources all stress that the final critical decision is often made in real time during the arthroscopy. So what are the non-negotiable biological and mechanical factors that determine whether we can even attempt a repair?
The clinical decision is, it's a complex balance of biology, biomechanics, and, honestly, patient compliance. We start with the biology, which is dictated almost entirely by the blood supply. It's all about vascularity and thus the location of the tear.
Okay, let's delve into that vascular anatomy. We know the meniscus is relatively avascular in the middle, but where does that peripheral blood supply come from, and how far does it really penetrate?
The blood supply is restricted to the outer rim. It originates from the microvascular parameniscal plexus on the periphery, which is fed by the medial and lateral geniculate arteries. If you're looking at, say, figure 39.1 in the surgical anatomy stack, you can see this dense network surrounding the horns. But this supply is highly constrained. It extends only 10 to 30% of the meniscal width medially and 10 to 25% laterally. The rest of the central meniscus is, while it's biologically inert in terms of healing, it relies solely on synovial diffusion for nutrition, which severely limits its intrinsic healing potential.
And this vascular limitation is why we absolutely have to stick to de Haven zones. They're our crucial surgical roadmap, right?
Yeah.
Can you explicitly define those zones for us and tie them back to that 30% vascular penetration limit?
Absolutely. These are the zones that literally define our success rates. If you look at figure 39.2, it lays it out. First, you have the red zone. This is the peripheral 3 millimeters, totally vascularized by the parameniscal plexus. Tears here have the best ability to heal, excellent blood flow. This is the ideal tear scenario. Then you have the white zone. These are tears located more than 5 millimeters from the meniscocapsular junction. They are avascular. They have very poor healing rates, making repair highly tenuous or sometimes just contraindicated. And then in between, you have the red-white zone. This is the transition area where healing potential is variable, and it often requires some sort of biological augmentation to push the success rates higher.
And they're anatomical curveballs too, right?
Of course. The lateral meniscus, for instance, has the popliteal hiatus. That's a gap in the meniscocapsular attachment where the popliteus tendon passes through. This creates a relatively hypovascular area in the posterior lateral meniscus, even on the periphery. And that adds another layer of complexity to repairs in that specific, tricky location.
Okay, moving from location to the actual tear configuration, it seems not all tears are created equal when it comes to mechanical fixation. What tear orientations are the ideal candidates for these repair devices?
The ideal candidates for any repair device, and you can see this clearly illustrated in figure 39.3, are longitudinal vertical tears, classic bucket handle tears, and meniscocapsular separations. These tears allow for excellent, clean side-to-side coaptation of the tissue edges.
And the success of that coaptation goes right back to the meniscal infrastructure, the complex organization of the collagen bundles, like we see in figure 39.4.
This is where biomechanics really meets the repair technique. The entire meniscus is built predominantly of those strong circumferential collagen bundles, designed to resist that outward hoop stress. Longitudinal tears run parallel to these major fibers. This orientation makes them highly amenable to fixation because the repair suture, ideally in a vertical mattress configuration, can be oriented perpendicular to those major circumferential bundles. That maximizes the mechanical capture and the stability of the repair. Conversely, horizontal tears, or cleavage tears, are less amenable because the fixation often runs parallel to the collagen. That offers mechanically inferior stability and a higher chance of the suture just cheese wiring through the tissue.
What about radial tears? They typically extend from the central avascular white zone outward. Are they ever structurally worth fixing, given their poor vascularity?
Radial tears are usually deep into that avascular zone, you're right, but they are critical to address if they cause instability. They have to be fixed peripherally even if the tear extends centrally, simply to preserve the remaining peripheral rim and, most importantly, to restore those vital hoop stresses. If we don't fix an unstable radial tear, it's like taking a rigid wooden barrel and just splitting one of the staves. The whole structure collapses under pressure, the radial tear functionally opens up that circumferential ring, and the entire meniscus fails to distribute load effectively. So we have to fix it to restore that circumferential function, even if the central portion just scars over.
And of course, tear size is a critical indicator.
Yes, we use rough guidelines. Tears that are longer than 4 centimeters are typically considered unstable, they have a poor prognosis for healing, and they're often difficult to even reduce arthroscopically. Tears shorter than 1 centimeter are generally considered stable and may be managed non-operatively. When you're dealing with highly complex tears, multiple flaps, horizontal cleavage, or degenerative tears, which represent chronic, systemic tissue damage rather than an acute injury, partial meniscectomy is often the most appropriate and durable management option.
Okay, finally, let's address the contextual factors. Younger patients heal better. That's pretty obvious due to better cellular health. But the timing of the surgery and the simultaneous management of the ACL seem to be perhaps the most influential elements in dictating whether a repair is successful.
The timing is clear from multiple sources. We see improved results when repairs are performed less than 6 weeks from the initial injury. But the ACL connection, that's truly profound. It provides a powerful, natural, biological boost that we absolutely must leverage. Meniscal repair success rates are significantly higher in the setting of a concurrent anterior cruciate ligament or ACL reconstruction.
Why is there such a dramatic difference? Is it just the static stability from the new ACL graft, or is there a deep biological mechanism at play here?
It's the biologic component that's doing the heavy lifting. The acute trauma, followed by the surgical debridement and reconstruction of the ACL, creates a highly favorable biologic milieu within the joint capsule. This process involves massive local bleeding and an acute inflammatory response, which introduces a high, concentrated dose of pro-inflammatory cytokines, chemokines, and critical growth factors, things like platelet-derived growth factor and transforming growth factor beta, right where the meniscal repair is taking place. It essentially turns the knee into a high-octane healing environment, maximizing neovascularization, even in that tricky red-white zone.
So the ACL surgery is inadvertently serving as a high-powered, localized biological augmentation.
Precisely, and we see the clinical data bear this out powerfully. A retrospective study on fast fix repairs, for example, showed a 14.5% failure rate with concurrent ACL surgery. That dramatically contrasts with a 27% failure rate when the meniscal repair was performed in a knee where the ACL reconstruction was delayed or just absent. This suggests that if a patient has an ACL tear, performing the meniscal repair concurrently provides a powerful, natural, and free biological augmentation. If the ACL is not reconstructed, the meniscal repair success is severely jeopardized, and repair may indeed be clinically contraindicated in unstable knees, even if the tear morphology looks perfect.
I find the technological evolution in orthopedic devices just fascinating. The rapid progression, the push for novelty, and then the inevitable, sobering clinical reality check. Can you walk us through the generations of all inside repair devices and the specific problems each one tried to solve, only to introduce new ones?
It's a classic surgical narrative. We're trying to achieve the gold standard fixation, that inside-out vertical mattress, while avoiding the primary risk, which is the neurovascular bundle. This evolution has been an iterative process, often driven by the desire to simplify a technically demanding procedure while minimizing risk.
Okay, let's start with the first generation, the initial attempt to truly go all inside.
That was Morgan's all-inside repair from 1991. The goal was to pass sutures across the meniscus and tie them arthroscopically. The major limitation, however, was that the technique required these specialized curved instruments that necessitated using accessory posterior portals.
So right away, it's not really all inside.
It immediately defeated the purpose of reducing risk. The technical challenge. I mean, it was like trying to tie your shoes with chopsticks through a keyhole while blindfolded, and operating millimeters from major vascular structures. The risk was just too high, and the procedure was quickly abandoned in favor of safer alternatives.
That failure directly paved the way for the second generation, which focused on bringing the entire procedure safely through the anterior portals.
Correct. The T-Fix device from Smith & Nephew was the key player there. It used a small polyethylene bar placed peripherally, attached to a braided polyester suture. The concept was simple. Deploy an anchor bar to capture the peripheral meniscus or capsule, and then secure the tear by cinching down adjacent sutures with arthroscopic knots tied inside the knee. This system successfully proved it was possible to repair the meniscus safely through anterior portals, dramatically minimizing that neurovascular risk compared to the first generation.
But the T-Fix had a major mechanical Achilles heel in the form of the knots themselves, right?
They absolutely became the problem. The arthroscopic knots, sitting proud on the superior surface of the meniscus, were a potential source of chondral abrasion. They would slowly scrape against the femoral condyle with every single movement. Furthermore, the inherent limitation of a manually tied knot is that once you place it, the tension is fixed. You couldn't retension the repair if it loosens slightly. That meant the compression across the tear might not be optimal, or it might degrade very quickly.
Which brings us to the third generation, the era of the notorious rigid bioabsorbable devices. The arrows, the darts, the staples. This period felt like a huge technological leap forward, but it was followed by a major step backward in long-term safety.
This was the rigid revolution, and it was epitomized by the meniscal arrow from ConMed Linvatec. These devices, if you look at figure 39.5, were rigid. They were constructed most commonly from polylactic acid or PLLA. They promised strong, fixed fixation and bioabsorption over 2 to 3 years. They were supposed to remain structurally intact for up to 12 months. The appeal was immense. Simple deployment, immediate fixed strength.
And the initial clinical results were excellent, which probably provided some false security.
They were stunningly good at first. Early studies reported healing rates over 90% at 2 years. But this is where the material science came back to bite us. The long-term data became profoundly concerning. That high initial success rate rapidly declined. The same cohort showed only a 71.4% success rate at 6 years. And even more alarming, in isolated meniscus repairs, so repairs that lack that crucial biological benefit of a concurrent ACL reconstruction, the failure rate with the meniscus arrow jumped to an unacceptable 42%.
Wow. So the material itself was structurally failing over time, especially when biological healing was poor. But the complications were arguably the most devastating legacy of this generation, weren't they?
The rigidity and the degradation process were the dual downfalls. Let's talk about PLLA. It's a bioabsorbable polymer, but its degradation involves hydrolysis. The material slowly breaks down in the body through water absorption. This process often led to the creation of acidic byproducts and particulate matter, and that resulted in numerous adverse effects. We saw transient synovitis, chronic inflammatory reactions, and sterile cyst formation. More acutely, if you look at figure 39.5, parts D and E, you can see the gross consequences. Device failure, fragmentation, migration resulting in painful nodules.
And the chondral damage risk from migration or proud placement, I mean, you've seen these long-term follow-ups. What were the consequences of putting a rigid implant in such a dynamic high-load environment?
This generation was the mechanical equivalent of putting a rigid steel scaffold inside a highly dynamic articulating joint. The idea was great, but the biomechanical reality was just brutal. I recall a follow-up where a patient presented years after an isolated arrow repair, complaining of this intense localized pain. The second look revealed that a migrated, slightly proud PLLA device had caused significant grooving, almost a permanent channel, in the opposing femoral condyle. The damage to the articular cartilage was irreversible. Because of these unacceptable failure rates and the potential for these devastating mechanical and inflammatory complications, rigid third-generation devices are now almost universally abandoned in modern practice. We had to pivot entirely to a fixation system that was not only low profile but fundamentally flexible and stronger in the long term.
The lesson from the rigid era seems crystal clear. Dynamic joints demand flexible fixation. This brings us to the fourth-generation devices, designed explicitly to solve the rigidity issue and, critically, allow for variable tensioning after placement. These are the modern suture-based systems.
Precisely. The focus shifted entirely to maximizing fixation strength, using flexible sutures and creating low-profile anchors. We needed materials that were stronger and way more biocompatible than PLLA.
Let's start with the fast fix system from Smith & Nephew, which really perfected this approach.
The Fast Fix is the poster child of the fourth generation, and it's now evolving through material upgrades. The current Ultra Fast Fix uses two 5mm anchors, and crucially, the anchor material is peak polyether sarcotone, which is known for its excellent strength-to-weight ratio and superior biocompatibility compared to PLLA. It minimizes those inflammatory reactions. The connecting suture utilizes UHMWPE ultra-high molecular weight polyethylene, specifically their Ultra Braid, which provides incredible strength and a very low profile.
And the technique itself is designed to be safe from the start, mitigating that persistent neurovascular risk.
Yes. The delivery system uses a straight or curved passer that's equipped with a depth-limiting sleeve. This sleeve is crucial for safety. It ensures the surgeon achieves adequate insertion for fixation while stopping the device from penetrating too far deep toward those posterior structures. A depth of 12 to 13 millimeters is typically sufficient and is deemed safe for deployment.
And the major mechanical revolution here is the prettied slip knot system.
That is the core mechanical advantage over the older T-Fix. The Fast Fix deploys two anchors connected by a suture with a pretty slip knot. After both anchors are placed in the meniscal tissue, typically in a horizontal or vertical mattress pattern, which you can see in figures 39.6 and 39.7, the surgeon manipulates the prettied slip knot using a push-pull technique. This allows for variable and highly controlled compression across the tear after the anchors are seated. Unlike the fixed, unadjustable knots of the T-Fix, this system lets the surgeon confirm ideal coaptation and tension arthroscopically, ensuring there's no unnecessary laxity.
Speaking of mattress patterns, this brings us back to the most fundamental biomechanical concept, the superiority of the vertical mattress configuration over the horizontal. We need to be absolutely explicit about why this mechanical difference is so critical for long-term survival of the repair.
This is a point that cannot be overstated. If you recall those circumferential collagen bundles designed to handle hoop stress, a vertical mattress suture is the only way to apply tension perpendicular to those dominant load-bearing fibers. You capture both the superior and the inferior layers of the meniscal leaflet, and you apply maximum compression across the tear interface. This ensures maximal mechanical capture and stability. Studies confirm this pattern offers superior load-to-failure strength.
Whereas a horizontal mattress
A horizontal mattress suture, conversely, runs parallel to the main collagen bundles. It's easier to place, sure, but it results in mechanically inferior fixation. The tension is applied with the direction of the load, making it prone to pull-out or cheese wiring through the tissue over time. Achieving that vertical mattress configuration with modern all-inside devices is key to matching the biomechanical integrity of the gold standard inside-out repair.
Okay, so if vertical mattress is the goal, how does the Omnispan from DePuy differentiate itself from the Fast Fix system?
The Omnispan uses a similar foundation, two peak backstop anchors and UHMW PE suture, and it also allows for vertical mattress placement. The key design distinction, and this addresses that old T-Fix problem, is the placement of the slipknot. In the Omnispan, the knot is integrated and rests on the peripheral capsule at one of the backstops. This means that no knot rests on the articular surface of the meniscus. This low-profile peripheral knot placement virtually eliminates that persistent risk of chondral abrasion that's inherent to any device where the knot sits directly on the articulating surface.
The fourth generation solved rigidity and tensioning. But now we're seeing the emergence of the all-suture, all-inside repair, which seems to represent a new frontier by focusing purely on suture capture, without relying on peak anchors that sit proud of the capsule. Devices like NovoStitch from Ceterex and the meniscal scorpion from Arthrex.
This is the latest evolutionary step, and it represents a paradigm shift back toward pure suture control. These systems use a specialized curved needle mechanism to pass suture entirely through the tear and then retrieve it arthroscopically. This allows the surgeon to tie a comprehensive, customized suture loop, a true circumferential stitch, as you can see in figures 39.8 and 39.9. They let us bypass rigid anchors altogether.
And what's the mechanical advantage of that circumferential stitch compared to even the vertical mattress created by an anchor?
The primary advantage is creating highly uniform, adjustable, and powerful compression. This circumferential suture fixation wraps around the tear, applying perpendicular tension across the entire tier's edges. It just optimizes the coaptation forces better than a simple two-point fixation. The NovaStitch system in particular offers incredible versatility. Because it's based on suture placement rather than rigid deployment, it can be used for every configuration: vertical, horizontal cleavage, complex root tears. And importantly, it allows excellent fixation in notoriously difficult spots like lateral meniscus tears right at the popliteal hiatus.
And the data supports its mechanical superiority, or at least its equivalence to the gold standard.
Absolutely. Biomechanical studies demonstrate that the NovoStitch is comparable to the inside-out repair in terms of load to failure. And crucially, for those function-critical radial tears, repair using the NovoStitch showed a significant decrease in tibiofemoral contact pressures, comparable to the inside-outside repair techniques. It truly signifies a leap forward in fixation versatility and the ability to achieve a robust circumferential repair almost anywhere in the meniscus.
Okay, so even with all this technological finesse, we're still operating in a millimeter-precise environment. If all inside devices avoid those accessory posterior portals, how do we manage the persistent and inherent neurovascular risk, especially when we're working on the posterior horns of the menisci?
The risk is never eliminated. It's managed through vigilance and precise technique. The most concerning complication remains damage to the popliteal artery or an injury to the tibial or common peroneal nerves. Even all inside techniques require the instrument or the needle to traverse a significant tissue depth to capture the meniscocapsular junction or the peripheral rim for posterior horn fixation.
What does the cadaveric evidence tell us about how close our instruments are getting to these critical structures?
It should make any surgeon nervous. A crucial cadaver study by Cohen and his colleagues showed explicitly that when deploying all inside devices in the posterior horn, the passing needles frequently came within millimeters, single-digit millimeters, of the popliteal artery. That margin for error is non-existent.
So if the instrument trajectory is that tight, what specific non-negotiable safety protocol can surgeons use to physically increase that safety margin, particularly for lateral meniscal fixation?
The answer lies in patient positioning. The position of the knee is the critical variable that moves that neurovascular bundle out of harm's way. Kueller et al. Performed a pivotal cadaver study specifically examining the distance from the posterior horn of the lateral meniscus to the popliteal artery and the peroneal nerve using the FastFix. And they found the single safest position for fixation of the posterior horn is with the knee in 90 degrees of flexion.
And why exactly does 90 degrees of flexion provide that safety margin? What's the mechanism there?
It's a tensioning effect. When the knee is flexed, the soft tissues, including that neurovascular bundle, are relaxed and slightly pushed posteriorly. This increases the distance from the posterior capsule where we're deploying the anchor. The moment you move the knee toward extension, that distance rapidly decreases, dangerously tightening the relationship between our device and the artery. For posterior lateral fixation, 90 degrees of flexion is mandatory for maximizing safety.
Beyond the catastrophic neurovascular damage, let's revisit the mechanical complications. How have things like device migration, misfires, and pullout evolved with these newer suture systems?
Well, we've largely eliminated the PLLA-induced inflammation and the growth chondral grooving, but the mechanical complications have just shifted profile. We still deal with anchor pullout, especially if the tissue quality is poor. We deal with deployment issues like misfires, where the mechanism deploys the suture before the anchor is fully seated, or tangled sutures that require immediate arthroscopic retrieval. A surgeon has to be constantly vigilant for the device being placed proud or the knot resting awkwardly.
As a resident, one of my fears is deploying a device and not being totally sure if the placement was successful. Are there tactile or auditory cues we should be looking for?
Absolutely. Beyond the visual confirmation of coaptation, a successful deployment should provide a distinct tactile feedback, a firm seating, often an audible click depending on the device. Then, the immediate post-placement test is crucial. You gently challenge the fixation arthroscopically to confirm robust tension. If you see the anchor or the suture move excessively, or if you feel any laxity at all, you have a high risk of failure.
And finally, let's talk about failure evaluation. If a patient comes back symptomatic 6 months later, how do we definitively know the repair failed? Especially since the remaining scar tissue might obscure a re-tear on an MRI.
Evaluation of failure is notoriously challenging with a standard MRI because it struggles to differentiate healed fibrous tissue from residual tear instability. Often, we have to rely on MR arthrography, which uses a contrast injection to better delineate the tear boundaries. However, the true unequivocal gold standard for confirmation of failure is second-look arthroscopy. This provides the definitive visual confirmation of non-healing or re-tear, and, crucially, it allows us to immediately proceed with revision management. We can either attempt a revision repair if the tear morphology permits, or, more commonly, perform a partial meniscectomy to address the symptomatic tear.
We've established that mechanical fixation is crucial, but it only buys time for the biology to kick in. Given the notorious avascularity of the white-white zone and even the red-white zone, how are we actively trying to manipulate and improve the biologic milieu to encourage actual durable healing where nature often fails?
The entire field is moving toward engineering a healing response. The goal is to maximize the expression of pro-inflammatory cytokines and growth factors to promote neovascularization. We use both mechanical stimuli and direct biologic delivery.
Starting with the mechanical stimulation techniques, what is the goal of rasping?
The simplest and most widely used technique is rasping. You can see it in figure 39. Jessa. This involved arthroscopic abrasion of the torn meniscal edges, often using a rasp device. The mechanical trauma is deliberate. It's meant to promote a healing response by inciting localized bleeding from the peripheral vessels and triggering that necessary inflammatory cascade. It's essentially a controlled injury intended to bring healing factors to the zone.
And then there's the more aggressive approach of trephination. What's the benefit versus the controversy there?
Trephination involves using a spinal needle to create vascular channels that extend from the vascular periphery toward the avascular zone. Theoretically, they act like tiny conduits for blood and stem cells. The benefit is clear: you're creating direct channels. The controversy, however, is that this mechanical trauma may cause further damage to the existing meniscal infrastructure, potentially destabilizing the pier site and creating new failure points. The data isn't unilaterally positive, so it has to be approached judiciously.
Moving to true biologic augmentation, the use of a fibrin clot seems to be the oldest, most established, and maybe the simplest adjunct.
It's the original biological scaffold. A fibrin clot, shown in figure 39.11, is created from autologous blood. It provides a structural matrix and a natural source of growth factors. You place it directly into the tear gap. Early animal models showed clear evidence of enhanced healing in avascular tears when they were augmented with clot. Clinically, trials like the one from Henning and his group demonstrated that clot augmentation significantly reduced failure rates compared to repair alone. It's an inexpensive, readily available scaffold that bridges the gap and delivers those initial signaling molecules.
And then we get to platelet-rich plasma, or PRP. This is a massive area of research, but the clinical data, as you mentioned, is often conflicting. Why the disparity in results?
PRP is derived from concentrated autologous platelets, and when it's activated, it releases a potent cocktail of growth factors. The theory is fantastic. We are turbocharging the healing process. However, the reason for the conflicting clinical evidence lies almost entirely in preparation variability and technique.
Preparation variability. You mean there are different types of PRP?
There are significant differences. PRP can be broadly classified based on its white blood cell content. Leukocyte-rich, or LRPRP, or leukocyte-poor, LPPRP. LRPRP contains higher levels of inflammatory cells, which some believe are beneficial, while others argue they promote catabolic or scar-forming activity. LPPRP might promote a cleaner, less inflammatory healing response. So if one surgeon uses a highly inflammatory LRPRP preparation and another uses a mild LPPRP preparation, and they both just call it PRP, their clinical results are likely to be wildly different. This just undermines any attempt at meta-analysis. For example, that retrospective study comparing isolated meniscal repair with and without PRP showed no significant difference, but it likely used a preparation that wasn't optimized for meniscal healing, and the study was underpowered anyway. We need standardized, high-quality trials, specifically testing optimized preparations, like the one being injected in figure 39.12.
So it sounds like we are currently performing research on an apples-to-oranges basis because the product we're calling PRP isn't uniform at all.
Exactly. The lack of standardization in concentration, activation, and composition is the primary hurdle preventing PRP from becoming a standard of care technique in a missile repair right now.
Looking further out, what represents the ultimate solution, especially for those large avascular tears that currently mandate a meniscectomy?
That is the cutting edge, tissue engineering. Researchers are focusing on biologic structural scaffolds combined with stem cells to actively regenerate true meniscal tissue. We're investigating a variety of advanced materials, collagen-based, hyaluronic acid-based, and synthetic polymers like polyglycolic acid and polylactic co-glycolic acid. These materials are designed to degrade into harmless substances while maintaining structure.
And the goal is to create true fibrocartilage, not just scar tissue within that defect.
Precisely. And the early findings are extremely encouraging. Studies using animal models have demonstrated meniscal-like tissue formation using hyaluronan collagen composite matrices combined with mesenchymal stem cells. Other in vitro work has shown successful proliferation and differentiation of meniscal-derived stem cells when utilizing hyaluronic acid scaffolds. This strongly suggests that a combination of a structural scaffold and stem cell technology could potentially allow us to achieve successful, durable, organized repair even in the central avascular white zone, which is currently a functional black hole. That would be the ultimate game changer.
We've covered the biomechanics, the mechanical fixation, and the future of biological enhancement. But all this intricate surgery is, well, it's worthless if the patient doesn't adhere to the postoperative protocol. This final phase, the diligent post-op care, is often the hinge upon which success swings.
It is the most challenging component, particularly when you're dealing with young, motivated athletes. We need to explain the why behind the restrictions, which brings us right back to the dynamic biomechanics of the loaded knee.
How does simple weight-bearing compromise the repair, especially for those posterior horn tears?
It's a kinematic nightmare for a fresh repair. Weight bearing, especially if the patient allows any knee flexion, drastically increases pressure on the meniscal tissue, directly stressing the suture lines. And even worse, when the knee moves from full extension into flexion, there is a posterior translation of the femoral condyles relative to the tibia. This motion creates a massive shearing strain vector that pulls directly across the posterior horn repair. If the repair hasn't had adequate time to establish fibrous union, the strain can easily lead to anchor pullout or suture failure.
So given that shearing and compressive stress, what are the mandatory requirements for the postoperative protocol to physically protect that repair?
The protocol has to be rigid and strictly adhered to for the initial healing phase. First, weight bearing. The patient has to maintain strict toe-touch weight bearing only on the operative extremity for several weeks. No actual loading is permitted. Second, quadriceps function. We have to avoid knee flexion during weight bearing until the patient achieves adequate quadriceps muscle function to stabilize and dynamically control the joint. The quadriceps acts as a crucial dynamic protector of the repair. Third, flexion limits. Deep flexion, think squatting, deep lunges. Any excessive tibial internal or external rotation must be strictly avoided for a minimum of 4 months. These motions place the highest strain on the posterior meniscal tissue and have to be controlled in a brace. And finally, return to sport. Avoidance of all high-impact athletics, specifically activities involving running, jumping, or cutting, is recommended for at least 4 months, and often stretching to 6 months, depending on the surgeon's preference and the patient's progress. The healing process is slow. Patience is paramount.
To bring all these concepts together, let's summarize the 4 major factors that we know, based on all this extensive literature, portend a good, durable result with meniscal repair.
We can confidently synthesize our findings into 4 critical prognostic factors. 1. Location and type of tear. A peripheral vascular location, red-red, or in a amenable red-white zone, and a longitudinal, clean, unstable tear that allows good coaptation. 2. Young age of patient. This correlates directly with better native cellular healing capacity. 3. Concomitant ACL reconstruction. This provides both static stability and, critically, a powerful, favorable biologic milieu for healing. And 4. Tear instability. This is counterintuitive, but unstable tears, when successfully reduced and fixed, tend to show better long-term outcomes than marginally stable tears that you might be tempted to manage non-operatively.
In focusing on the all-inside technique specifically, what is the core conclusion about its current place relative to the traditional gold standard?
The core conclusion is optimistic. Meniscal repair, when it's feasible, is absolutely preferred over meniscectomy. The all-inside technique, particularly utilizing the current generation of flexible suture-based devices, is now consistently demonstrated to be comparable to the inside-out gold standard in terms of mechanical stability and load-to-failure strength. And crucially, it achieves this result with drastically reduced surgical morbidity, lower neurovascular risk, and decreased surgical time.
But the clinical caveat remains the quality of the fixation pattern that's achieved.
Exactly. The success of the modern all-inside approach is entirely contingent on the surgeon's ability to achieve that biomechanically superior vertical mattress suture pattern. Given the longitudinal orientation of the meniscal collagen, Only that vertical mattress fixation, with tension applied perpendicular to the load-bearing fibers, provides the necessary added strength and stability for successful long-term healing. If achieving that vertical mattress configuration is mechanically impossible because of the tear configuration or an extreme peripheral location, the inside-out technique, despite its risks, may still remain necessary to ensure adequate gold standard fixation.
This has been an incredibly detailed deep dive into the evolution of meniscal fixation, moving from rigid bone-chewing rods to these sophisticated low-profile suture anchors. The focus has entirely shifted to maximizing that perpendicular fixation.
The progress has been tremendous. But as we maximize the mechanics, we now have to dedicate equal effort to optimizing the biology. We need to standardize and optimize augmentation rasping, fibrin clot, and especially the future of PRP and stem cell-based tissue engineering. That's the frontier for the notoriously difficult tears.
And that leads perfectly to the final provocative thought we want to leave for you, the listener, to explore further. We know that concurrent ACL reconstruction provides a powerful, positive, and non-negotiable effect on meniscal healing because it floods the joint with growth factors and stability. So, given the strong promise shown in preliminary research regarding standardized stem cell delivery and composite matrices, how soon will biologic augmentation cease to be an optional adjunct and instead become a standard, non-negotiable requirement for achieving predictable, successful repair in the most challenging avascular zones of the meniscus?
It's no longer a question of if we can repair the meniscus, but how we can force it to heal where nature previously dictated failure. That standardization of the biological response is the final major key to preserving the knee joint for a lifetime.
Thank you for guiding us through this extensive stack of surgical notes and technical details. This was truly a deep dive.
My pleasure.
We hope you gained a comprehensive understanding of the indications, the history, and the future of all inside meniscal repair. Thank you for joining us.